Hey everyone, so this is going to be the last chapter for Unit 6. It's going to be the shock states and hemorrhaging uh, emergency directives, or content for patient care theory. It's going to go alongside the hematological emergencies and the IV and medication therapy chapters that we already covered. Trying to, anything else to really... This video is a little late coming out. I recorded it all last night and turned out my microphone wasn't actually recording, so I'm going to be in the market for buying a new microphone, I guess. Can I say? Yeah, if there's any background noise, it shouldn't be too bad. Hopefully I had to go out and hide in my RV. I have my kids and everyone's home, so it was a little crazy inside the house. So hopefully there's not too many hiccups or any problems with the recording, and we can get through the content. It's the first part here, the hemorrhage control and hemorrhage content's pretty light. It's a lot of stuff we've already covered, so hopefully it's a review for a lot of the actual content that I end up reviewing today. So here we go. So when we look at shock states and hemorrhaging, the big problem or the big concern we have with any kind of hemorrhage is that we're going to end up compromising the cardiovascular system and its ability to effectively perfuse the body's tissues with oxygen-rich blood. It's not to say it's just we're looking for the oxygen-rich blood. We're also looking to get rid of waste products, get rid of carbon dioxide. A lot of these things that we've talked about when we're looking at the cardiovascular unit last unit, and then even when we started talking about the respiratory system and the lungs function as far as expelling of carbon dioxide and other products. Other important tissues that we're looking to perfuse with perfusion obviously is the brain. Obviously it needs glucose, oxygenated blood as well to keep it functioning, so it can control all the other bodily functions, and kidneys for metabolism or secretion of like waste products and other metabolic compounds that we don't really need in the body, uric acids, electrolyte imbalances, stuff like that. So we're going to talk a little bit about how fluctuations in perfusion pressures can kind of compromise these systems. And then we're also going to talk more on this video. It's going to be more about the actual hemorrhaging part and what we're looking for as far as bleeding, whether it be internal, external, and what indicators we can look at in the actual pre-hospital setting to help us kind of structure or guide our care plan or treatments for these patients. When we're looking at the cardiovascular system as far as a shock standpoint or hemorrhage control standpoint, traditionally we think of like the heart vasculature. We also kind of lump in the lungs in there as well because it's in charge of oxygenating the blood. When we look at it from a shock and hemorrhage control standpoint, we're really just looking at the closed circuit of the cardiovascular system itself. So we have the pump itself, which is the heart, the fluid, which is the blood, and then we have the hoses or the pipes, which would be our veins and arteries. So in order to keep perfusion up through this whole system, it kind of relies on it maintaining it being a closed circuit system, because as soon as you open up, like I don't know if anyone's ever worked with I don't know, even say if you had like a sprinkler or something like that, or you're hooking up like a kid's slip and slide or fun sprinkler thing, if there's a hole anywhere in that hose before it gets to the end of that hose, you're likely not going to have the pressure required to perform the function or deliver whatever it is they're trying to have at the end of that hose. So again, perfusion, just to remember, I know, like I said, I feel like I'm beating dead horse at this point with perfusion. It's the effective pumping of blood through the lungs, where it picks up oxygen and it'll dump off carbon dioxide, and then eventually pumping that oxygenated blood to the tissues wherever it might be in the body, where it'll offload the oxygen pick up waste products, pick up carbon dioxide, and bring it back to the lungs for exhalation. I'm hoping by now that most of us are pretty well versed with the that's what I'm looking for, how the heart kind of works as far as the anatomy and physiology of it. Just as a quick recap though, remember we have our left and our right side of the heart, and each side is responsible for kind of pumping to its own designated parts of the body. So when we look at shock states, it's important to think of, yes, the heart is one, large muscle that functions, to pump blood through the body. But when we look at perfusion pressures and the heart's ability to actually perfuse tissues, it's important to remember that, no, it's not right. Blood leaving our right ventricle is going to end up going to the lungs. And that blood leaving our left ventricle, ends up going to your systemic circulation, right? And we've talked a little bit about this in the cardiovascular unit and cardiovascular emergencies, left and right side of the heart failure, what kind of signs and symptoms you can look for. If you're having failure on, this side of the heart, you're going to end up with fluids kind of backing up into peripheral vasculature. You get your JVD, peripheral edema. You might get, increased urgency to urinate, more frequency of urination. And that's just because, the kidneys are backed up with fluid. There's basically this backlog of blood working its way down system now. And it's kind of getting stuck in the, the venous return of the body. So we've talked about that. And we've also talked about kind of the same side on here. If you have left side of the heart failure where blood is backing up into this atrium and out to inevitably the lungs, you end up with pulmonary edema and your COPD, kind of CHFE kind of calls, right, where you have fluid in the lungs. You can get cardiac asthma, a few different things like that. When we're talking about shock states, though, and hemorrhage control, we're less concerned about the backlog of blood from like heart failure, and we're looking more to get rid of all these lines here. We're more concerned with the blood coming out of the ventricles now. So for the right side, it's obviously blood leaving the ventricles going to the lungs. So if you try to picture it on the other opposite end of congestive heart failure symptoms, is, what happens is if I don't get enough perfusion to the lungs, what would be my signs and symptoms of that? What could I have, show as a complaint or a problem with the patient? If there was a heart failure where they're not pumping adequately to the lungs, you can be having increased dyspnea. They could have, increased work of breathing on exertion, lethargy, things like that, where, there's signs and symptoms that the blood isn't circulating through the lungs properly, and the tissues that need oxygenating blood or oxygen aren't really receiving what they need. And if you look on the opposite side here now, when you look at systemic circulation, this would be the more profound symptoms that we could really assess in the pre-hospital setting. They're easy to kind of look at. You got your signs of say like hypotension, where your blood pressure is dropping because the left ventricle isn't pumping out enough blood. You could have signs of they could be completely unconscious. It can be difficult to rouse. They could have weak pulse rates, irregular palpable pulses, just because every contraction of the heart isn't actually generating a palpable pulse. So that's kind of the way I look at it, is instead of looking at congestive heart failure, where it's kind of backlogging of blood, we're looking at how much blood is actually coming out of the heart, and making it to systemic circulation. So that's kind of the way I think about the pump part of our cardiovascular system and, you know, cardiovascular problems that arise from it. There's obviously going to be parts with the vascular makeup and the blood makeup, which we're going to talk about once we get into those topics. But as when we look at, like, we're going through these, I want you just trying to keep in mind the heart and how it's outputting blood, and, you know, what changes in the body or changes in the heart's ability to pump might look like as far as output to the tissues they perfuse. So along with thinking of how the heart's actually moving blood through either the pulmonary circulation or the systemic circulation, a few terms that I know we've already covered quite a few times in patient care theory, but they're kind of good to kind of keep fresh in your head when you're looking at the systemic or pulmonary circulation of blood. And it's important to kind of think about how we're going to discuss how the heart kind of compensates for these you know, changes in blood volume, or, you know, there's a patient's experiencing some kind of shock state. The heart will try to modify some of these values or some of these aspects to kind of increase its response to, you know, a loss of blood volume. So the first one is preload. We've talked about this quite a bit with the cardiovascular unit. Remember, this is like the passive filling of, you know, whether it be the atria or the ventricles, kind of at when the heart's at rest still. So that preload is kind of going to help the heart more effectively increase its stretch, which will inevitably increase the amount of blood that it can contract and squeeze out per cardiac cycle. So I think of preload as that pre-contraction. It's kind of like that passive, you know, if there's a lot of blood pressure in your systemic circulation, it's going to kind of fill that right atrium a little bit more than it normally would if it was a low blood pressure. So it's that passive kind of fill of the chambers. Afterload would be almost the exact opposite. If you think about after the contraction, it'd be the amount of pressure that's kind of exerting itself back on the heart. So it would be like a back pressure of systemic pressure. So this kind of happens during, you know, contraction of the ventricles. So it'd be the, you know, things like if you have, you know, obesity, atherosclerosis, arteriosclerosis, stuff like that, that actually increases your vascular resistance. This would increase afterload, and it's more work against the heart for it to pump against. Finally, cardiac output we've talked about as well with stroke volume. So stroke volume is the amount of blood that's actually ejected with every contraction of the heart. We can't really measure that in a pre-hospital setting, obviously. It's more of a diagnostic tool they use when they're doing CTs or angiograms of the heart to assess its output. And then cardiac output would be, you know, the amount of blood that's ejected with each stroke. So each stroke volume output, and then you multiply that by the heart rate per minute. So, and that would give you a liters per minute value for that patient. And I think that's all I have on this one. So I'll go to the next slide here. So ejection fraction, this is going to be a new terminology unless you've covered it with an A&P. But ejection fraction or ejection percentage is the amount of blood that's actually ejected from a chamber. So whether it be an atria, ventricle, they even use this for, you know, blood supply returning to the heart from vascular return in the legs. They use it for the gallbladder secreting, you know, bile, stuff like that. It's not really just a thing just for the heart. It's pretty much any hollow structure or organ that's able to secrete a fluid. They try to measure what percentage of that fluid's actually contracted or squeezed out of that organ per pump or cycle or contraction. So if you look at the ejection fraction for the heart, for example, it's most commonly used for the left ventricle, and it'd be the ejection fraction. So when we look at things like preload, which we just talked about, if you have a left ventricle that's being preloaded more, so stretched, filled with more blood, and even if we say, I don't know what the actual, you know, normal ejection fractions are, but say if you had 90% ejection fraction in the left ventricle, and the ventricle is filled with, I don't know, we'll just say, just to keep it easy, we had 100 mils of blood in there. If you were to, eject 90% of that, it would be 90 mils. So no matter what amount of volume is filling this ventricle, it's always going to be the same percentage of that amount. Like the ejection fraction per person is always the same. It's a consistent number. So it might not be the same from person to person due to other like health problems or comorbidities, but it's that kind of concept of, the greater the stretch, the greater the squeeze, the greater amount of blood you can actually push out of the heart. So, going back to preload, if the heart is preloading and, filling itself up, stretching itself out with more blood in it, it's able to effectively squeeze more of that blood out of it per contraction. Okay. So next on our list is actually, we're going to start talking about the blood now. Again, this is going to be mostly a review. I'm not going to dwell too much on it because we talked a little bit about it with the hematological emergencies, and I think you've gone through it quite a bit with A&P from the discussion we had during that chapter. But the important thing to remember is that our blood is, made up of a few compounds. So it's not just, red blood cells floating around or whatever you think it might be, like one thing. It's a combination or a mixture of, different cells doing different functions, and they all play a role in, all vital functions of the body. When we look at, shock and hemorrhage control and our body's ability to compensate for bleeds or other, kind of complications that are leading towards hypovolemic states, or not even just hypovolemic, we'll say shock states where blood pressure drops for certain reasons. The blood is able to, in conjunction with the heart, respond to that in certain aspects. But there's also some, aspects of the blood that actually kind of contributes to certain shock states. So having a good understanding of each of these, cell types, when you look at like our red blood cells, obviously are responsible for carrying O2. White blood cells are for immunity, platelets, clots, and plasma. It's kind of like I always think of it as like the, like your highway or the conduit that everything's kind of, mixed into, right? It's also responsible though for, electrolytes. It's, got glucose in there. Most of our CO2 that we exhale is actually diffused into plasma. It's not carried by blood cells. So the plasma itself, while it's, its role is to kind of be the medium that everything flows through, it also has a lot of important roles as far as transportation of hormones, electrolytes, ions, inorganic things like glucose. I guess glucose technically be organic. Anyways, but like salts and other things like that as well. So when we look at the breakdown of what we're concerned about with blood, obviously red blood cells. So, you want to have all these in kind of like a proper proportion, because, you can have blood that's consistent with just these and you'd have a normal blood pressure. But if you're not actually circulating anything that's going to carry oxygen for you, it's kind of a moot point, right? So having all these different components are obviously important to, proper health and the well-being of the patient, or, any of us really. We talked a little bit about, imbalances in these cell types when we're looking at the hematological emergencies or problems chapter. But the big thing I always think about too is, especially in our care, is when you're dealing with injuries or shock states or hemorrhages and like bleeding problems, is we always like to start, IVs on these patients, and we're going to run lots of fluids through what's called a bolus. So a bolus is just a large administration of fluids kind of given at one time, like it's a big squeeze of fluid. And that's usually to help, boost our plasma volume. But the important thing to remember is when we boost a plasma volume, all you're inevitably going to be doing is just diffusing the the actual blood. So your red blood cells, your blood pressure's now gone back to say normal-ish, but now you have, you know, an X percentage less of red blood cells circulating. You have less white blood cells in the circulation as well. You know, your platelet factors and other clotting factors are now decreased. So when you look at actually trying to manage the symptoms or the patient's overall ability to kind of recuperate from, you know, a shock state or a hemorrhage like that, just providing fluids alone, while it will help bring back up perfusion pressures, it might not always be the solution for the patient if they've lost, you know, a certain amount of a specific cell type that's needed by the body. One thing to remember that's important though with plasma, it's you know, most of our blood volume is made up of plasma. There's nothing else really I need to add. I don't think that you probably already don't know about these cell types. We already discussed a lot of the kind of patho of white blood cells to the amount that we need to know. We don't need to go into a whole immunology course about it. The other thing kind of going alongside with the red blood cells, I kind of just mentioned a few minutes ago here, but if you dilute blood as well on the platelet front, so if you're trying to manage a wound, or, you know, you got like a amputation or a large laceration somewhere, and, you know, you're running fluids through an IV line somewhere and you're giving them large volumes of fluids through that IV, the longer that the IV runs and the more of our normal saline or just salt water or whatever you want to call it, whatever helps you keep that in your head, but the more normal saline that we have getting pumped into that patient, the more diluted their clotting factors are going to be, and the more difficult time the body will inevitably have at you know, eventually clotting up that injury. Do we have... I don't really want to talk too much about vasculature. I think we were all pretty well versed on. I know with A&P, I looked at your slides from that. You're pretty comfortable with what an artery is, what a vein is, you know, looking at the thicknesses of the walls. Arteries are thick-walled, high pressure. They have the ability to contract because they have that muscular layer. Veins, on the other hand, they are thin-walled, low pressure, have valves in them. They don't really have a muscular wall. They're not able to kind of constrict themselves and control bleeds as actively as an artery. The last kind of, you know, portion of that would be your capillary beds. And if you remember, at the beginning of a capillary bed, there's kind of a shut-off valve for the arterial, or whatever you want to call it, there, can constrict itself and shut off that capillary bed. So when you look at bleeds in capillary beds, are really effective at, you know, controlling those, which we'll talk about here. So that A&P part of vasculature is kind of going to be a little bit relevant to this part of the course. So just, if you're not very comfortable with it, maybe take a refresher and go back and look at those diagrams if you have a chance. So the next thing we're going to touch on is, now that we kind of discussed the blood, and, you know, I touched briefly on vasculature, so kind of bring it all back together as you look at perfusion. And there's certain structures or organs in our heart that need constant perfusion of blood. You know, so those systems are going to require oxygen and glucose, these kind of, you know, metabolic in and out constantly, or else those organs fail pretty quickly. And it's going to be the responsibility of the autonomic nervous system to automatically, hence probably the name, kind of manage the blood flow to these systems. So the most obvious one that we just talked about again last unit is going to be the heart. So if you think about, you know, any kind of skeletal muscle you have, if you're to say contract it, you know, once every 4 seconds, even after a few minutes, it would get quite tired, and you wouldn't probably be able to keep doing it over and over. So the fact that the heart's able to beat, you know, 60, 70 times a minute, and it never fatigues, it's always able to keep, you know, going cycle after cycle, is a pretty good testament to the ability of the heart. But it's also a testament to how much, you know, demand of oxygen and, you know, waste removal it needs to keep going effectively and not have any problems. So, you know, if you think of where our coronary arteries come from. So you have your aorta that comes off the top of your heart. Your coronary arteries kind of stem right off there, right? So it's always got the closest supply to blood, so it's always going to supply itself with blood first before anything else. So um, the heart constantly needs perfused blood, or else it's going to start having failures. When you look at, we talked about myocardial infarctions, we talked about angina pains. Those would be what you're going to start to experience as soon as you have like we spoke before, if your cardiac output or your cardiac oxygenated blood isn't meeting the actual myocardial demands that the tissues are demanding. Second down the list is the brain. You can last about 46 minutes without freshly perfused blood. Obviously, you're going to probably have a kind of a gradual decline in function through that kind of 4 to 6 minute period. Confusions, altered a level of consciousness, things like that, right? So after that point, the brain ceases to function properly. And then finally, kidneys, which are kind of high up there as well. I remember I talked about it a few minutes ago. There is they require a kind of a usually a adequate amount of pressure to actively filter out waste products from the body. And if you think about it in the flight or fight response, is your body is trying to use a lot of its muscles to run or fight or whatever it might be. So it's going to be building up and burning off a lot of these waste products. So it's trying to keep the blood, healthy and able to perform well by filtering out these waste products as effectively as it can. So for some reason, though, if the kidneys aren't perfusing, whether it be from a bleed or a shock state, they have about 45 minutes until the tissues in them start to deteriorate and break down. And again, so these top three here, those are kind of controlled by your autonomic nervous system. So, those are kind of like your alpha beta receptor organs, where your brain dumps epinephrine, norepinephrine, and all of a sudden your body's shunting blood away from the extremities. Your fingertips aren't getting oxygenated properly. Your blood's getting kind of redirected from your feet and your toes, and it's getting kind of pushed towards your core so that it can circulate blood actively through your heart, brain, and kidneys, and help you do whatever it is that you need to do to get out of this fight or flight situation that you're in. Down here, the skeletal muscle, it can go for about 2 hours or over 2 hours, it says. And if you think of situations where you're out in the cold, for example, say out for a hike and your feet are cold or your hands are cold and they get kind of, like that frost nip where they're starting to get white, they're cold, they're hard to move, they feel really stiff. That's, effectively there's no real good perfusion of blood through those or those tissues at this point, right? So, if you're out for an hour and a half and 2 hours and you're out, with cold hands, you're able to kind of reperfuse those tissues. You get that pins and needles. You probably have muscle cramping and pain, but the tissues don't deteriorate or break down immediately. They're able to kind of tolerate a time frame without active perfusion. The last one they had, I didn't have it on the list here, but is your GI tract. And it was about 3 to 4 hours of low or hypoperfuse. The GI tract never will ever not have any perfusion. It's always got kind of passive, just due to its connection to the descending aorta, abdominal aorta, and stuff like that. It's kind of lined in directly with that. But there's periods, like I said, if your fight and flight response, where blood is getting shunted away from your GI tract in order for you to use it for fighting or saving yourself or whatever it might be. So that's a situation where it's going to be poorly perfused. It's going to be underperfused, if anything, and it can sustain that for a few hours. But again, like I've talked about this before with the cardiovascular system, people that are having a huge sympathetic response, if they're having like a heart attack, or their blood pressure is dangerously low, or something along those lines, where there's something kind of very drastically that's changing in the body, they'll get that sympathetic surge. So their body's going to send out all of those epinephrine, norepinephrine hormones through the body, and that'll actually cause people to either, you get that vomiting response. It can actually cause them to urinate. It can cause them to defecate. And that's kind of like involuntary. They can't control it, but it's just because their GI tract now is not getting perfused, and it's basically saying, get rid of everything that's in there because I can't function with food that's in here now. There's something going on, and we need to get rid of everything in order to focus on just pumping blood through the heart and getting into the brain, kind of thing. So if you're ever on a call and you're dealing with somebody who looks ill and they've had an uncontrolled bowel movement, it's usually a pretty clear alarm that there's something pretty severe going on that you might want to be on the lookout for. One thing to remember, I wrote down here at the bottom, is all of these times are kind of taken at the assumption that the body's at the normal body temperature of around 37 degrees Celsius. As we talked about before, as soon as you start decreasing that temperature, metabolic cell function actually starts to slow down. Metabolic processes slow down. Waste products don't build up as quickly, and oxygen demand would actually lower as well. So if you deal with somebody who's, I don't say hypovolemic, but if they've had poor perfusion and they're out in the cold, they're less likely to have injury or problems, as say if they're at normal body temperature. So sometimes when you go to the hospital and they're dealing with a difficult cardiac arrest patient, or if there's a patient that's unstable and dealing with a lot of bleeds, sometimes they'll actually actively keep the patient cool to kind of lower the metabolic demand on the body. But that's kind of like I think I've only seen that once. They call it therapeutic cooling. Nothing that we do in the pre-hospital setting, though, so nothing that we really need to worry about. So continuing on into the actual discussion now about hemorrhage. The important thing to remember is hemorrhage is considered bleeding. It's a synonymous term. It's interchangeable. One's more of a layman's term, and the other one is your medical terminology. There's no grading of hemorrhage. It's not like you say one thing's a bleed and the other thing's a hemorrhage. If it's greater than a certain size or something like that, it's interchangeable completely. So a bleed, whether it be a paper cut or a huge laceration within a spurting artery, it's going to be considered a hemorrhage regardless. Minor or major, that'd be the arguing factor you'd probably want to put in there. When we look at hemorrhages, though, so we'll start with looking at external ones. They require a break in the skin. That's going to let the blood actually leak out to the surface. I can't think of any other way you'd get any external bleeding without a break in the surface. Anyways, so I know we've talked about this before, but remember when you're looking at an injury, you can kind of assess the type of bleeding that's occurring, and you can kind of use that information or use the visual cues of the bleed to get a good guess or good I don't want to say guess. You can evaluate what kind of structures or damage or vasculature might be involved with the bleed. So when you're looking at just general oozing, usually bleeding will kind of be self-sustained, kind of control itself. You're going to assume it's going to be a capillary bed bleed. So usually these bleeds are, dark in color. They don't really, like I said, they usually don't require much intervention or management. Usually it'll be like a 4x4 with a piece of tape or a Band-Aid on it. They'll usually start clotting themselves up. And if you remember looking at your capillary beds, I'll just draw a really quick and ugly one here. Anyway, say this is your capillary beds. Before every capillary bed, the actual arteriole is able to kind of clamp down and close off that whole section. So if there's a laceration here, for example, it'll detect that and it'll send chemical messengers backwards towards the injury site, and it'll actually clamp off and close that capillary bed off. So typically with capillary bed bleeds, you don't really need to do much as far as an aggressive management. Venous bleeds, on the other hand, they kind of can go either way. They, depending on the size of them and the patient's comorbidities and health status, you can have a venous bleed we kind of say those kind of flow blood out. They're usually a pretty steady flow, and they're going to be dark in color as well because it's deoxygenating the blood. The thing is, when you look at veins, is so if you remember, we have all of our valves that kind of prevent backflow on them, right? So that's going to prevent a lot of the blood from flowing back down out of the vein. The problem is any blood moving up forward is going to be just continuously pushed by, the arterial pressure and muscular contractions, because that's where most of our venous return comes from, is, muscular contractions, and also breathing even just, has enough of an effect to actually create pressure on the venous side of the circulatory system. So these veins, depending on where they're actually lacerated, they can actually lose quite a large volume of blood. Because if you remember from the A&P part, I'll just draw one quickly here. If you have an artery, it's got that, thick muscular wall here, which allows it to kind of clamp down and cinch itself off, and it'll kind of it'll try to occlude the bleeding itself or constrict itself to the point where it's not bleeding anymore. Veins, on the other end, have that really thin muscular wall, so it's not able to effectively kind of constrict down as well as the arterial side of it could. So vein, we've had issues with people with like varicose veins in their legs, for example. We've had people that, have called and said they've, cut their leg on something by accident, and it's a varicose vein that's bleeding, and they'll lose a significant amount of blood. And we've actually had patients go into shock states and actually succumb to their wounds from, nicking a varicose vein and inevitably bleeding out from it. Arterial bleeds, these are going to be your Hollywood bleeds, or your big spurting lacerations, amputations, where the blood's just kind of spurting out like they would in a 90s Hollywood kind of like horror movie. Blood's going to be bright red. It's freshly oxygenated. So, but you're thinking again, when you look at the high pressure sides of the cardiovascular system, right, is if you put a nick in any part of that high pressure kind of pipe or the tube that the arteries are, the blood's just going to kind of come out of the high rate, high volume, high pressure. Arterial bleeds are going to be the most difficult to probably control. They're going to require, direct digital pressure, tourniquets, likely, depending on how aggressive the bleed is. And, these are the ones that are going to likely need some kind of surgical intervention at the hospital. A few things to remember when we look at vasculature is, I should probably just delete this and I'll redraw it again, is when you look at your vein, or your artery, I should say, sorry, if there's a laceration in it and it's only a partial laceration, say something like that, the muscles that kind of travel transversely through this part of the vasculature, they're not going to be able to complete that imaginary circle around here to constrict it, right? So if you imagine those myofilaments trying to constrict down and squeeze that portion of the artery down, it's not going to be able to do that because it's not a complete loop around the actual lumen. So it'd be like having this and, you took a chunk out of it like that. It's not going to be able to pull itself closed. So when you deal with lacerations where it ends up being, either like a shear, like a tear of an artery, or a crush, for example, where the artery is actually damaged that way, or a partial laceration of it, the artery has a lot harder time constricting itself down and actually try and tamponade that bleeding and control it on its own. So clean cuts, usually, as sick as it kind of sounds, they'll be able to be controlled a lot easier than a kind of a rough or a crush injury of some sorts. So moving on to internal injuries. One thing to remember with internal bleeds is that depending on the cavity that they're actually kind of occurring in, it's going to determine, so the cavity size is going to determine the actual amount of blood you're going to lose through in that internal bleed. I shouldn't say how much you're going to lose, but how much you could potentially lose into that cavity. So if you think of something like the pelvic cavity or the thoracic cavity, those are very large areas of body, or volumes of body, I should say. So if you have a bleed in your thoracic cavity, oh man, or in the pelvic cavity, there's a lot of space there for blood to occupy, which obviously we don't want to happen. But then if you think on the other hand, something like the interstitial spaces in like your thigh muscle, or something like that, or your forearm, like if you get a bruise there, you're not going to lose a lot of blood into those interstitial spaces because there's not really a lot of room for blood to take up. It's not like a hollow organ or hollow space. So we want to keep that in mind when we're looking at tamponading, things like pelvic splinting, stuff like that later on in this chapter. I'm going to touch on it again. I know we've already talked about it before. So internal bleeds can be caused by trauma. Obviously, it's the one everyone kind of goes to. If you think of like blunt trauma to the abdomen, for example, or if you're in a car accident, you're wearing a seatbelt and you get that kind of shearing injury. T-bone car accidents where you can get flung left and right. So those are called shearing pains, or shearing injuries, I should say, sorry. Those would be like where you get your abdominal dissections, or your aortic dissections, I should say, and internal bleeds that way. Things like pelvic fractures, what are some other pneumothoraxes, like hemopneumos. So you get internal bleeding into the thoracic cavity. So these are kind of injuries that might not be outwardly overt immediately, but they'll start to present signs and symptoms throughout your call, which you'll hopefully be able to pick up on after we talk about this stuff in this course, or this chapter at least. The next one's going to be GI bleeds, so anything in the gastrointestinal tract you're looking at, rectal bleeds, peptic ulcers, any kind of bleeding in the GI tract. If you're looking at the large small intestines, you can have lesions, polyps, stuff like that. So those can present, we'll talk about it in a few slides here, but those can present in different ways, and there's certain kind of hallmark presentations you should look out for. Ectopic pregnancies, so if a female is say she has an egg that's still in the fallopian tube and it's become fertilized by a sperm, and it starts to grow or implant somewhere in the fallopian tube instead of making its way to the uterus, that fertilized egg will start to grow and grow, and eventually it'll reach a point where the fallopian tube can't obviously handle that stretch anymore, because it's not really meant to have a baby grow in the fallopian tube, obviously. So at some point, you're gonna end up with a tear and trauma on the inside of that abdominal cavity at some point at the fallopian tube, which is going to be a surgical repair that's going to be required. Aneurysms we talked quite a bit last unit about, but again, you're looking at your dissecting aneurysms, AAAs, aortic aneurysms, stuff like that. And finally, I added in clotting problems. We talked about DIC, hemophilia. So you have these patients that might have kind of these chronic conditions, but they might not have any outwardly overt or obvious traumatic injuries, but they might have, bumped into a table the wrong way, or they'll some weird obscure story, and you might not think that there's anything really odd about that, but it could be something that's potentially causing a hemorrhage internally that you can't really assess. In either cases, whether it be an external or internal bleed, if we're deeming it to be a severe bleed, or if we're assuming or have the notion that it might be a severe bleed based on the MOI and incident history, the best intervention we can do is to initiate if severe. rapid transport of these patients is going to be the most important thing, getting them to the hospital so they can get those surgical interventions they need to actually repair the traumas or the bleeds, whether I shouldn't say traumas, they're not always traumas, but they need to have the bleed repaired surgically is what I'm trying to say. So if we can initiate the rapid transport, and then we're going to start, symptom relief for shock symptoms, it's going to be our best course of action for these patients. So, fluid boluses, if it's trauma to the, say, like the pelvic ring or something like that, where we can tamponade it with a pelvic splint, then we'll do that. If it's, applying tourniquets for hemorrhage control, those are kind of the tools that we have available to us to help mitigate these injuries or these symptoms. I added also down here, when we're looking at internal bleeds, relying on the mechanism of injury and incident history, those are going to be the best pieces of information we have to try and lead us towards diagnosis or deciding on what kind of injuries they might have, whether they be internal or external. So the external injuries are obviously a lot easier for us to see and kind of make a diagnosis that way, but it's the patient who is wearing their seatbelt in a car accident and got hit in the side. They have no outside injuries, they seem fine, but they're complaining of a little bit of abdominal discomfort. They say they feel like they have some cramps, and then maybe they're saying, no, I don't want to go to the hospital, but you spend 50 minutes on scene and they're they're saying these cramps are getting worse, and maybe they're starting to get diaphoretic, short of breath, and you do an abdominal assessment on them, and then you see there's rigidity in the abdominal cavity and maybe some signs of bruising in their flank sides or something like that, and you're like, oh, there's some internal bleeding that's likely happening. So now you're going to be racing to the hospital to get this patient seen. Discussing the hemorrhages as well. It should also be noted that anytime we find a hemorrhage, we should try to control it as soon as we can. If it's something that's largely uncontrolled and an imminent threat, that's something that as soon as you identify it on your primary assessment, you're going to want to address it right away. If you find a hemorrhage and it's something that you think is more of a minor, non-threatening bleed, then it's something you can probably skip over and come back to after you've ensured there's no other immediate life threats on that patient at that time. But just remember that you should address any kind of bleeding at some point, whether like I said, if you have a huge overt bleed, that's going to be something you're going to want to address right away on your neck to knees. But if it's something minor, you don't want to leave it open and make it all the way to your hospital and all of a sudden be like, oh, I didn't address that bleed. So make sure if you identify any kind of injury, you address it at some point. Always better sooner than later. But if you have to skip over it to get to more severe injuries or more severe complaints, whether it be respiratory distress or hypovolemia or something like that, then just make sure you get to it at some point. So another important point is, if you can't control any kind of bleed in a pre-hospital setting, it's obviously going to be a load and go decision at that point. You're going to be making that, it's going to be kind of like swapping out C in your ABCs. Like, and the inability to control that bleed is going to be your C. So now instead of a situation where you're doing CPR, you're going to be actively trying to control that bleed, whether it be with direct pressure, tourniquets, whatever tool it is that you're using. That's going to be your whole job until you get to the hospital at this point. Things like they say here, arterial bleeds can take over 5 minutes to actually develop a clot and start to slow the bleed. So if you're aggressive with your dressing and your bleeding control, it is something that you can manage in the pre-hospital setting. It's something you're gonna have to be a little bit patient for. It's not something you're gonna be able to rapid dressing on and say, oh, it's good. You're likely, if it's an aggressive bleed, you're gonna have to be aggressive with management to get the results that you're looking for. Looking at internal bleeding, we are obviously ill prepared to actually manage those in the pre-hospital setting. So we only have really therapies that help, mitigate or reduce the symptoms or the extent of the bleeding, but we have nothing to actually help resolve it effectively. Like I said, we have things like pelvic bandages or pelvic binding, which helps to increase or decrease the volume of the pelvic ring, but nothing that is going to obviously take the place of like a surgical intervention. So this next portion here, we're going to be talking about blood volumes and blood loss. One thing to remember that's important is, people in general aren't really great at, visualizing a spill of fluid on the ground to determine what the actual volume is. No one's really that great at it. If you take into account that there's factors like different surface types, whether it be dirt, carpets, mattresses, car seats, and then debris and stuff like that can be also involved. It's really difficult in the pre-hospital setting to really get a good determination on how much blood has been lost in a traumatic situation or a GI bleed or something like that. So we can try to take it into consideration, but it's not something you're ever going to be really accurately provide. It shouldn't be tailoring your symptom relief or nothing like that. So one thing, like when we're looking at blood volumes, I think you guys have talked about this with anatomy and physiology, but you're looking at about 70 mils per kilogram of weight for an adult male. That'd be their blood volume, and then for a female, it'd be 65 milligrams per kilo. And then don't forget, when women are pregnant, they can actually increase their blood volume of up to about 45%. So you're looking at almost 150% of that normal blood volume now in their vasculature. Again, so when you're looking at issues where you're concerned about bleeding, whether it be internal or external, you're dealing with a lot more. You're dealing with two patients first of all, and then as soon as perfusions kind of get dropped, the first thing that the body's going to do is try and keep circulation to the mother's core. So then you're worried about perfusion to the umbilical cord and the fetus, obviously. So we want to be especially cautious. We want to be very aggressive with our care and ability to bring these people to the hospital when you're dealing with comorbidities like pregnancies and situations like that. So I have the pediatrics. I do. Okay. So it says the body can tolerate about an acute loss of blood about 20%. So if you look at a 100 kilogram male based on these calculations, you're looking at about 7 liters of blood or 7,000 milliliters. 20% of that would be about 1,400, right? So about 1.5 liters, if you lose that quickly, they're gonna have decreases in their blood pressure. Their heart rate's going to be increasing, trying to compensate for that. They might have an increased respiratory rate because now they don't have as much oxygenated erythrocytes floating around to oxygenate their tissues. So with a 20% loss, you're going to have an acute, change in their vitals. They're going to have, a systemic response to that change in hemodynamic stability. The textbook said, generally over 1 liter of blood loss, you'll start to see those vital sign changes. And those are the ones I just mentioned earlier. And I added a note here that the body's ability to actually compensate or to make up for that loss will depend a lot on how quickly that blood's been lost. So situations like if you think of going to blood donation clinics, is they'll donate blood over 20 to 40 minutes depending on how well the patient's doing. But they usually have no problems donating that blood over that time frame, and it's about 500 mils. So that's a pint of blood is 500 milliliters, and they can usually get up and walk away from that with no problem. If you were to donate 500 mils of blood to say a side of the road in 10 seconds or 2 minutes or something like that from a car accident, the body's ability to respond to that might be completely different because it's not going to have the chance to actually compensate for that sudden drop of pressure. So again, it's going to be dependent on the patient, their comorbidities, and kind of like the timeline of this injury. One thing to remember, I've always reiterated this in all of our lectures, but pediatrics, they have a lot less blood, obviously, than an adult would if you look at the milliliters per kilogram kind of calculation. So that I wouldn't say the liter of blood thing's going to be the same for them. It's going to be, I would go based more on that 20% calculation because, yeah, the same effects are going to be visible probably by losing a lot less blood than a liter. I might as well continue on from here, I guess. So the next discussion is about the trauma triad of death. So these are going to be things that you'll find that are going to kind of contribute to a patient's morbidity status. So if you find one of these three on a patient, it's going to basically prevent them from clotting up as effectively as they normally would. And it's going to basically, contribute to the patient's inevitable demise, I guess you could say, or their death. So if you have a patient who's hypothermic, they're not able to clot up their blood as effectively. Their clotting factors aren't going to work. Vasoconstriction isn't going to work as properly. And it's not actually going to be able to cinch off that blood vessel effectively enough to control the bleed. Coagulopathy. So that's the actual clotting factors in the blood. If there's like I talked about, DIC and hemophilia, but if there's any other kind of issue, if they're on a medication like blood thinners, anticoagulation therapy, stuff like that, having these in their system, this is going to make them, more susceptible to succumbing to their bleeds because they're not able to actually effectively clot their own injuries, whether they be internal or external. And then finally, acidosis. If the patient's in, a acidotic state, a lot of the metabolic functions in the body. So if you look at things like their, even you look at, again, like arterial constrictions, that's the big one, like their actual ability for the vasoconstriction to happen. What else could I say? Clotting factors, other proteins aren't going to be really, they're going to start to denature if they become too acidotic. What's the other one? Hormone response. They're not going to work as they normally should if the patient's in an acidotic state. So if you think of somebody who's been, say, hypoventilating, or if they've been apneic for an extended period because they've been overdosing on opiates and now their body is in respiratory acidosis, those patients, if they were to have a bleed as well, their bleeding would not be controlled as effectively as somebody who wasn't in an acidotic state. And if you remember, again, we should try to put ETCO2 on a lot of these patients so we can assess any signs and symptoms of respiratory acidosis. So, that buildup of carbon dioxide in the body. We can use end titles to really get a good kind of understanding if that's, a factor that's going to be affecting our patients. That's not to say if you're dealing with somebody who's has an amputated leg or something like that, I wouldn't be putting ETCO2 on them first thing to see if they're acidotic or not. But, it's a value that can kind of give you maybe a bit of an insight onto the patient once you get other things managed a little more effectively. I should also touch on significance of bleeds. So there's a slide here. It's slide 39. And basically it's going to kind of go through a few things that, when we're looking at, I can just do this actually. Looking at bleeds. So when we look at a significant MOI, so that's going to be more for your internal bleeds, obviously where we can't really see the bleed externally. So it's going to be, looking at force of impacts, getting a history of the collision or whatever the event might have actually been from bystanders. But if you have a clear idea of the forces that are exerted, especially on like chest injuries, abdominal injuries, stuff like that, you can kind of make a determination on how severe the bleeding is going to be based on that MOI. If you find a patient and they have some kind of an MOI that's indicating that there's a potential for injury or trauma, and they have a poor general appearance, so we always say in the field, like, they kind of fail that look test where you look at them and they're like, oh, they look like you know what. That's usually an indication that that you might be dealing with something a little more occult that's not really apparent on your initial walk up of the patient. Just based on looking at them, they look like junk, but there's no real injury that you can see. Then there might be something internally going on that you need to try and investigate for. Obviously, if they have signs and symptoms of shock, that's going to be a good indication that you should be aggressive with what our treatments are going to be. Significant amount of blood loss. Again, based on our abilities, it's not very, we're not very strong at getting accurate readings on what blood loss is on whatever we're looking at, the road or somebody's floor. But if you look at something and say, holy, that's a lot of blood, then probably a good indication that you need to be aggressive with your transport and your care for that patient. And again, going back to hemorrhages, if it's any kind of uncontrolled hemorrhage where you've done your interventions, you've done the care that you can, and it's still not able to actually control that bleed, then this is going to be a serious, traumatic call or hemorrhage call that you're not able to really manage in a pre-hospital setting. I already talked about these before when we were looking at the different vasculature, but keep in mind your types of vasculature. If there's a bleed from an artery, it's bright red, spurting. Venous is dark red, steady flow. And then your capillary beds are just kind of like that general oozing with, they'll usually kind of tamponade themselves or control their own bleeds after a certain amount of time. And then finally, they say here, I already talked about this too, but medications, they can inhibit clotting functions, the ability for some of the vasculature to actually constrict sometimes. Things like severe injuries or multiple injuries, they can actually, if clotting factors are being directed, various parts of the body, it might not be able to effectively clot all of these injuries all at once. So if the injury is severe enough or if they're widespread enough, it might not actually effectively clot these up enough. So just be on the lookout for failures in our hemostatic system that way, or the ability for our body to kind of clot itself up. And the other thing I mentioned earlier is if you got damage to part of a vessel wall, or if it's kind of like a shearing, tearing of a vessel wall, it's not going to be able to constrict properly and try to control that bleeding on its own. We just talked about the triad of death. Next thing's going to be about patient assessments and stuff. So I'll create another clip here. So one of the last couple things I'm going to go over for the hemorrhage stuff for this chapter is bleeds in the GI tract. We've talked about this before, that blood introduced into the GI system doesn't really mix well with stomach acids and the other metabolic processes that are going on as far as digestion goes. So blood inside the GI tract actually causes quite a bit of irritation and other symptoms that we'll discuss here briefly. So a good thing to think about when you think of bleeds is they're going to kind of vary on their appearance based on where they actually occur in the GI tract. If you have a laceration somewhere in the throat or the mouth and that patient's spitting out blood, it's obviously going to be what we call frank blood. So frank would be bright red, distinctively blood. You can tell right away what it is. As we move further from, each opening, bottom or top, as you move further inward towards the center of the GI tract or deeper into the GI tract, you're less likely to see, it appear as normal frank blood. So the first kind of junction we get to is our stomach, which is where we have our hydrochloric acid, which, is involved with breaking down denaturing proteins, getting rid of the pathogens. And if you think of what hemoglobin is and most of our blood products, so most of it's water, which is not a huge problem for the stomach. But the rest is, clotting factors, hemoglobin, which are all pretty much proteins which denature as soon as they hit hit some kind of acid. So in the stomach, we end up with what we call as coffee ground emesis, and that's basically the blood product starts to curdle and it kind of turns into what looks like coffee grounds. If you ever cleaned out the tray in a coffee machine and poured it down the drain a little bit, you'll see what looks like traces of coffee. And it actually is a picture of it right here. That's exactly what it looks like. So, it's obviously going to change a little bit based on how much blood is actually in the stomach at the time of them throwing up. You might get traces of actual bright red blood depending on how active the bleed is. And you usually find this with like a peptic ulcer, or if they have, say if they had like a bleed in their throat or a nosebleed and they've been swallowing the blood, this is what it'll come back up looking like. So it's coffee ground emesis, and it's pretty, the namesake pretty much matches it. Now, once you get past the jejunum or the bottom of the stomach here and you get into the GI tract and the small intestine, it's usually not very often that things will back up and go the other way. The only time you ever really have to deal with that is if there's like a bowel obstruction where, for some reason there's a blockage here and the food only has one way to go and it's back up the way it came. And that's a whole other story we won't talk about right now. We'll talk about it later with GI stuff. But so when you have blood that's, say if you had a bleed, in your small intestine here, and that's leaking into your GI tract, and you're going to do the same thing. It's going to be broken down, so start to curdle, clot. A lot of those intrinsic kind of clotting factors are going to remain in the blood, obviously, because they're just sitting there in the intestine. They'll mix with stomach food contents, bacteria, all the other stuff that's normally in your GI tract. And what happens is you kind of end up with a black curdled, sludgy, not even call it like a fluid, but it's a substance, and they call it melena. And it's also called like a tarry black stool. So it doesn't look like normal feces or like that. It's very liquidy. And we're just lucky enough that we have a picture of it here. So they say tarry black stools. For some reason, if you put it on a white piece of something, you'll see it actually is red tinge still. So, yeah, it's, yeah. Basically, if you think about a large amount of blood that's made its way into the GI tract, it's had a chance to kind of start curdling, clotting. The proteins are still being denatured because of the stomach contents that are in the intestines. There's bacteria that are, trying to probably process some of it or digest it. So it's not going to look like frank blood at all. It's going to be, somewhat like this based on how far up the GI tract it is. So the further you are away from the end point here, the more and more unlike normal blood it's going to look. The last one you might see is, again, if you had say if you had a bleed in the large intestine and kind of like this last few portions here, you might end up what's called hematoschisia, which is basically just frank blood and feces mixed together. So, it's bright red blood, looks like normal blood, but it's got fecal content mixed in with it. So that's really the big ones that you have to kind of worry about, I guess, or if you see them, you should know what they are. There's other people, like a lot of times you get calls for rectal bleeds, and it could be something like hemorrhoids, which is just bleeding at the actual anal sphincter. That's not really considered to be an internal GI bleed. It's just a distended vessel at the anal sphincter. So, but it still might bleed, and it's obviously uncomfortable for some people, but it's not really what we would consider to be an internal bleed. So last thing I'm going to talk about here, I don't think I have the slide, I don't have anything on it, so is kind of bleeding control. We talked a lot about these with the trauma, soft tissue management and stuff like that in Unit 2, I think it was. But there's just a few things that I think would probably be good to touch on. Nosebleeds, you have the option of having the patient, sitting forward. So lean forward and have you know, making sure the blood's dripping out, and again, not back down the throat for the reasons we just discussed. And then when you're gonna do controls of bleeds at the nose, I'm sure everyone's heard of, like, you know, blocking your nose, but you want to pinch the actual near where the cartilage is up here, and pinch it up here to control the bleed. And some places actually have nose clamps. I'm not sure how effective they are. I've never really had them work very well for patients. They always tend to slide off. So what I usually do is I'll get like a towel or a 4x4 or something like that, and I'll get them to kind of, you know, press their nose, and they'll be able to judge how hard they need to press or not. But I always tell them, you sit there and that's all they're going to focus on, just holding their nose and leaning forward with it. And you work around them, you do your blood pressures and all that stuff that you need to do. If they need to get their wallet, you get it out of their pants pocket, whatever it might be. You want their sole focus to be just on sitting there and holding their face, because we don't have, what do they call it? When you go to the hospital, they have, it basically looks like a tampon, but it's a like a gauze compressed, it's not, what the hell do they call it? Anyways, it's basically a compression device, and they'll stuff it in there and it'll kind of swell up, and it'll kind of tamponade the bleed from internally. The other option is, if somebody who has these, you know, reoccurring bleeds like this, is they'll have to get it cauterized with, you know, electrocauterization. So we talked a lot about, you know, bleeding control as far as like pressure dressings, direct digital pressure. This is all in the BLS and should hopefully be review. You know, when we're getting to the far enough down our directive and we're looking at applying tourniquets, we really want to be certain that we've done a lot of our other interventions as effectively as we can, and you know, for long enough to give the injury enough time to try and clot without having to apply a tourniquet, because the tourniquet is really kind of like our last ditch effort. If you're I mean, if you're dealing with like an amputation, a little bit different of a story. You're not really worried about damaging too much of the tissues beyond the amputation site, because there's nothing there right now. But even still, when you look at possible like reattachments and stuff, you don't want to damage all the tissues at the actual injury site. So if we can control bleeds without having to tourniquet the extremity off, then we obviously want to try and do that. It should be our last ditch, last resort kind of thing. They talk about splints and stuff in here. I'm not going to go over that again. We've talked, I think, to ad nauseum about that. It's, you know, you're going to be going through it with skills class, and if you haven't already. One thing I'm not sure if we talked about in any detail is hemostatic dressings, or hemostatic agents, they call it. Hemostatic agents is really like a clotting powder. We don't really carry that. I'm not sure if there's other services that do. Most places are going to hemostatic dressings, which is basically the same idea, but it's got a dressing that has what's called like a chitosan, or it's a chemical that helps kind of elicit or promote clotting of blood. And this is usually based on some kind of shellfish derivative. I've heard of certain places, you know, asking if they have shellfish allergies as cause interactions, and I've also heard no, it won't cause interactions. So, you know, when you get to your placement, or, you know, wherever you end up working, ask and see what it is that they have in their directives for it. You know, when you look at like military applications, they have giant rolls of this stuff, and they'll just stuff it into gunshot injuries and wounds and stuff like that. So it works really well if it's applied somewhere where it's going to stay. It's not a dressing that you should be ever applying and then removing or like that. It has to stay kind of packed into where the injury is. Tourniquets we already discussed. Yeah, the last thing I wanted to talk about was pelvic traumas. So I know we talked about this before, because I remember trying to doodle this dumb thing before. But if we remember our pelvic ring, you know what, maybe I'll switch this so you can see what I'm drawing, not my face. Is say it's like this, right? And you have your pubis symphysis there, your vertebrae kind of attached into there, your whatever. Sacral spine is down there, coccyx, all that good stuff, right? Femur's head into there. I say it out loud like everyone should know what I'm drawing, but so the important thing to remember when you look at the pelvis is I always imagine it as a bowl. So if you had somebody laying on their back, the pelvis is going to sit like this, right? And I remember drawing this, so hopefully this is review for a lot of you. And it's the same thing front to back. So your spine kind of comes in flat like this. We say this is your spine here. The iliac crests scoop up like this at the front. And then your sacral spine comes up there. So again, you kind of have that bowl shape to it, right? Like if you imagine, just do it a different color. Just do it in a different color with bigger pen, right? So you get that kind of bowl shape there. So when we look at a fracture, and depending, tons of different types of fractures. But if you have a fracture that's at two sites, a commuted fracture, that's near the iliac crest and down near the pubis symphysis or something like that, you're effectively, what you're doing is you're breaking off a portion of that bowl. And what's going to happen is just due to the mechanics of gravity in our muscular system, is this going to get pulled downward. So we'll draw that. So we have a fracture there, and now you end up with part of your pelvic crest kind of sitting down like this. So essentially what ends up happening is if you were to do, say, the total volume of this versus, I'll just draw it in a different color, like this, when it wasn't fractured, there's an increased volume of space here. So as we discussed earlier when we were talking about internal bleedings will occupy a large volume of space if it's available. What we want to do now is try to find a way to move that piece back upwards so we can, what we call is tamponade that bleed. So if you think of like a cardiac tamponade where it's not able to contract or relax because of pressure on it, imagine if you had a bleed in your pelvic cavity and you're squeezing that pelvic cavity into a smaller volume, you're going to be essentially squeezing that bleed. So it's going to, what we call tamponade that bleed. So what we want to do with pelvic binding devices, for example, or a pelvic sheet wrap, is it's going to come around the pelvic ring. And remember, we want to go around the pelvis and not, so it should be wrapping around here. We do not want to wrap it just around the hips. If you apply pressure down here, you're not doing anything for that pelvic ring. So we want to get it up around the top part of the pelvis where the big iliac crests are. So if you put your, if you're to put your hands up on your hips, if you're going to, do a little dance or something like that, you can feel right where the top of your iliac crests are. So that's where these should be going. It looks like it'll be really high, but it's not where it's where it should go. And as we kind of pull tension on this belt or this swath that's wrapping around this patient, the goal is that this is going to pull that broken portion of the pelvis back up, sorry. So there's a few different devices out there. I know Sabri uses what's called, I think it's called a P-pod. And it basically looks like a women's corset kind of thing where it has like all the strings that go back and forth through it, and you tighten the string and it kind of cinches it all together. We use what's called it's a SAM X, not SAM XT. Well, it's SAM, but I don't know it's an XT. It's a SAM pelvic binding device. Same idea, but it uses one large ratcheting device. It's kind of like what we see on our tourniquets. And then you might have some places that right now don't have anything at all. I know the province is looking to move towards a more commercial device for everyone to use, but you might have somewhere that uses just a sheet. For example, you wrap a sheet around them, and you try to tighten that sheet as much as you can to apply that kind of medial pressure to the pelvis. And remember, anytime you have any kind of tourniquet pressure dressing, if you have a pelvic splint on like that, you should not ever have to remove them unless there's some kind of crazy change that happens. That's, you know, if you have say if you put a pelvic binding on or something like that, and all of a sudden they have gross bleeding or something like that happens from under the actual pelvic binder, then obviously you might have to remove it so you can visualize what's going on. But more often than not, once those devices are on, you write down the time on them and they stay on until a doctor removes them afterwards. As far as our symptom relief stuff, if you look in the ALS, you're looking at the IV infusion directive. So you're looking at large bore IVs. This is going to involve, you know, some math. You're going to have 20 mils per kilo up to a max of 200 milliliters of fluids that can be administered to people who are in, you know, hypovolemic issues or need fluid resuscitation. So be comfortable with the directive and kind of like what it's aiming to achieve. So you remember, you're trying to kind of boost up that missing plasma. And remember though, when we do that, we're not going to be adding anything as far as oxygen carrying capacity or clotting capacity. Remember, with the trauma triad of death, we're going to want to keep patients warm. This is going to help promote clotting factors to get to where they need to go. We want to make sure they're well oxygenated, that they're ventilating adequately so they don't become acidotic. And then you again take time to make sure you ask if they have any kind of medications there and that might prevent them from clotting up properly, as far as like blood thinners or anticoagulation medications. On the way to the hospital or in the time of your care with these patients, remember, you want to be doing serial vital sign assessments with them. You want to check for any changes in heart rates, decreases in blood pressures. That's going to give you an indication that you know, maybe the hemorrhage control that we've done isn't cutting it, or they might have another injury somewhere else that's not, you know, we haven't been able to assess yet, or it might be an internal bleed that we're trying to, you know, resolve or fight with. What else do we have here? All right, so that's all I'm going to say for hemorrhage control. It looks like this video recorded all the audio throughout the whole thing, so hopefully there's no issues with it. I'm going to probably later on this evening do the shock part now, because I was supposed to do that this morning, but with all these tech issues I've been having, I got pushed back about 12 hours now. So I'll upload this one, and then in the next 24 hours I'm going to have the other one uploaded. I don't think anyone's going to be watching it on Christmas Day, so get to it when you can. And then pharmacology I'll have up in the next 3 or 4 days as well. I work nights the next 2 nights, so you know, maybe if there's nothing going on, I'll do a recording. But till then, if you have any questions, again, shoot me an email. I'll try to get back to you as soon as I can. I'm generally pretty good with answering most of the questions. And if there's anything else that's not related to hemorrhaging or like that, you can shoot me an email as well, and I'll see if I have an answer for you. Other than that, I'll see you probably next time you watch a video, so maybe in 5 minutes, or if not, then whenever the next video is uploaded. Okay, take care, bye.